Hey everyone, I'm Travis and this is Abby. Welcome to Concussion, a podcast where we dive deep into the world of brain trauma, breakthrough treatments, and inspiring recovery stories. Join us for expert analysis, real stories, and eye-opening insights along the way. Let's get into it.
Welcome back, everyone. So we are reconvening after we have done an eye sync on Travis. But just to take a step back, my name's Abby. I'm a physical therapist, and I'm here with Travis.
Hey, what's up, everybody? I'm Travis. I crashed my motorcycle in 2016 and had a traumatic brain injury. All kinds of recovery going on. That's what we talk about. And Abby mentioned iSync, which is what we did last weekend, and we're working on that video right now. It's very, very, very interesting, and it's going to be over on our YouTube channel.
So what were your thoughts doing the iSync testing? I'll give a quick overview of what it is, and then I want to hear what your impression was actually doing it.
Okay.
So you're in a VR headset, and then I have a tablet where we go through different eye movement tests, and there's several cameras on each side that will watch what your eye does. And we go through the full battery to be able to get as much information as possible. The whole thing took about 10 to 12 minutes start to finish. What was your experience in the headset doing the testing?
So I thought it was very interesting. I like anything VR, or I like technology. So I thought that was a very cool process that I was completely unfamiliar with. I feel like I've used the Apple Glass before, like the Apple version of VR headsets, and I thought that they were like amazing. This really wasn't anything that was showing me like me on the moon or anything or any crazy stuff like that, but I'm very interested to get the results of what happened. Like I thought it was very informative how you could like print out what my eye was doing, and finding that my right eye was a little bit sluggish or not quite as on spot like as my left eye. I think that's very interesting, and I'm very interested to hear like how that correlates with like brain activity.
Yeah, and there's just tons of information that we get. And we went through each test because we can get immediate results, which is so helpful. And the part that we discussed afterwards is you're actually right eye dominant.
Yes.
So if your dominant eye is giving you congested or sluggish information, that could certainly relate to a lot more fatigue as you move through your day, because that's the eye that oftentimes is going to be giving information first for your left eye to follow. And if that's the one that may have some discrepancies in certain areas of your visual field, it would make more sense that the more you're visually engaged, the more fatigue you might experience.
Fatigue as in more than just my eye? Like, could it make me irritable as well? Like,
could make you tired overall. Yeah. So like, because your brain has to perform more work because the eyes aren't seeing the same thing in the same way, there's a lot more adjustments and feed forward and feedback information that your eyes have to analyze and compute, that it would make you more tired in several different components instead of just your eyes. And some patients can experience it as like, my eyes feel tired, I have eye strain or eye fatigue. Other people experience it as more of like a global fatigue.
Yeah, I think I kind of get both. So when you had pulled up, or when you had came into the office here, like I had just put on my like those blue blocking glasses that I wear all the time, because I felt like some strain in my eyes. Like, and I kind of had an interesting day. Like I had to drive almost all the way to Baltimore today, and that was kind of a pain in the butt. And get back to work, and work was kind of slow, but then, my whole drive home. So
I think we will get a lot of insight as to why driving is such a taxing experience for you. based on the eye movement. And I think you were even kind of surprised that some of the testing that we did had insight into different components aside from just eye movement. So we were able to do things that would assess your concentration and executive function and your impulse control, which a lot of times you wouldn't think that if we're looking at how the eyes move, we can learn about different areas that might not have direct correlations to just eye movement.
Yeah, because it does seem like, how could my eye movement tell me about my impulse control?
Right. And there's just so much that we can pull from that in how you are able to use your eyes to stabilize an object as your body moves, how you're able to orient your head and your chest towards an object. But even within just eye movement, different areas of the brain have different responsibilities to make that movement happen. So if, for instance, in your smooth pursuits, being able to track an object, we had you do it clockwise and counterclockwise. That tells us
that's like following the dot in, like around the clock.
Yep, in a circle like that. But functionally, that would be if I'm sitting on a bench and I'm watching a car go by me.
Okay.
That tells us information about what's going on in the front of your brain, in your parietal lobe, and even in your cerebellum all the way in the back of the brain. So just one eye movement captures 3 different sections that all have different responsibilities outside of eye movement. So if one side, one eye is a little bit slower to react or a little bit less accurate, we now have a better direction of where we would need to focus your rehab intervention to improve the efficiency of that area of the brain.
Gotcha. Now, those 3 areas of the brain that you mentioned, is there any redundancy built in those? Like if the maybe the occipital lobe doesn't quite see exactly what happens because my eye is moving a little bit slower, will the, say, cerebellum or the center of, what's the center of the brain?
So to answer the first part of that, are there any redundancies? Yes. So if we look at it from a much more broad perspective, your eyes will essentially do 2 things. They will either try to continue to look at something, or they're going to try to go look at something else. So within that category of it wants to stay looking at something, there is a certain area of the brain that is going to be involved in that process. So for instance, the ones I would qualify under that would be your smooth pursuits, clockwise and counterclockwise. You want to keep looking at something as it moved around that circle. Your VOR, which is your vestibular ocular reflex, and that comes from very, very deep in the brain. That is maintaining your eyes on an object despite movement of your head. We test that horizontally and vertically. And then your VOR cancellation. So all of those are in this category of I want to stay looking at something. And then I want to go look at something else is a different responsibility, a different computation, a different area of the brain in terms of your saccades, horizontal, vertical, prosaccades, and antisaccades. Now, the one overlap in that is when you're performing a saccade, when you go back and forth between 2 objects. So as I'm sitting here, I'm holding one finger up on each hand about a foot apart. So as my eyes go back and forth between those 2 targets, there's a period of time in which I stay looking at my finger before I go back to the other target. So technically part of that saccade is in that function of I want to stay looking at something. But in all those tests that I mentioned of I want to stay looking at something, your pursuits, your VOR, the fixation part of the saccade, each one of those involves a different area of the brain to make that visual function happen. But there is redundancy in the opportunity for the eye to stay in place, to stay looking at something. Now, the second part of your question was, if I understood correctly, is the different areas of the brain always involved in performing the eye function? Is that what you were getting at between like the cerebellum and the occipital lobe having to cooperate to perform a certain movement.
Correct. Do they always talk? Is there a pathway that's common? How do I want to say that? Is there like a specific pathway that those electrical signals follow every time when you're trying to, say, do a saccade, like focus from one thing to another? Is that going to be like a specific pathway?
Yes. To answer that very generally, yes. Now, when that pathway becomes disrupted, you experience fatigue and errors as the eyes are trying to figure out how to compensate around that or create a new pathway. Depending on what we notice in your tracings and eye movements, we can get a little bit more information about where that disruption might be, and then either use isolated eye training or train your body to recruit more in that area of the brain's responsibility to improve that function.
And there's like specific physical therapy that you can do so say that we said that the impulse control one, which one was that? The
anti-saccades.
The anti-saccades. So is there like a specific rehabilitation process that I can use to try to improve that? Because
Yes.
it was like 34% right or 24% right or something like that. So if there's a rehabilitation that I can use to get that to say like 50% or 60%, well, what's like primo? What's
good?
Yeah.
So it varies. It really varies depending on what you do with the rest of your life. Meaning, if you are a high level athlete, we need that to be like 90% or above.
90. So the anti-saccade, 90% or above.
At least that's what I use as my benchmark if you're a high level athlete, because you constantly need good impulse control in order to keep yourself safe in contact sports. So actually, I had a patient who was a triathlete and still is, and she had 100% on her anti-saccades.
100%?
After a concussion, yeah.
After, so did it drop off after? So she's a triathlete, she gets a concussion. Does her anti-saccades drop for a little while?
So when I did her initial testing, she had things that we could address in other areas of her eye movement, but her anti-saccades started off at 100% and have stayed at that. And it was, she'll know who she is if she's listening to this, guys. I told her that was the only time I've ever seen that high of a score right off the bat. But it's not common to see that after a concussion. In fact, anti-saccades are very closely correlated with individuals who have recovered from a concussion, and they might be 6 months out, a year out, 2 years out. We still notice that there's a difference in their anti-saccade performance compared to those that were not concussed. So it is incredibly unusual for someone to just, after a concussion, do incredibly well with that. But it is possible because not every concussion is the same. Her mechanism of injury was a little bit different. But I typically am seeing after a concussion somewhere in like anywhere from like between 40 and 60%. And then, yes, we do specific interventions to train that because it's such an important skill in sports. And like I said, they can be completely recovered otherwise. So if you don't know to test it or look at that performance, you're going to miss out on this big area that needs to be addressed in order for them to keep themselves safe in sports.
Gotcha. So can you give me an example of like what you would do to help improve that?
Sure. So for instance, today, have you seen online those reaction time trainers? It's essentially a bar that sits horizontally, and then there's these styrofoam batons that are like 8 inches long that hang from this bar. So the way it works is I have a remote and I can push numbers 1 through 6 and one of them will drop.
Okay.
You don't know which one. You're the participant. I'm the one with the control. I can hit number 4 and it'll drop. And when it drops, you have to react quickly and grab it. Okay. So that trains your visual reaction time. or just reaction time in general too. What I did today to train impulse control is I did a few rounds with an athlete of just catch this. And then they got good at it. They got their reaction time up to just catch it as it falls. I don't want it to hit the ground. I'm holding it at about their head or eye level, and then it drops and they just have to grab it before it hits the ground.
Gotcha.
Okay, so they don't know which one's going to fall, but they know they have to grab it. And then I had that athlete do that same thing while they were on a rocker board. So their body's moving front to back through their feet. So like their ankles are moving them front to back, and they're watching for these things to drop and they have to grab it.
That sounds awesome. Like that sounds very fun.
The impulse control side of it is I took 3 of the 6 and I marked them with pre-wrap, which is just something we have in the clinic that won't leave sticky residue. So I put pre-wrap around 3 of them. And I told the athlete, I'm going to drop them. Do not catch the ones that have pre-wrap. So I'll randomly select which ones drop, but they had their brain expecting anytime I see something drop, I'm going to grab it. But now they have to think about, do I touch that one or not? Do I let it fall or do I catch it? And it has to be a very fast decision based on the information that they say. And then to take impulse control even further, I switched it. So after they got in the habit and got very successful with letting the ones with pre-wrap drop, catching the other ones, now I switched it to you only catch pre-wrap, let the other ones fall.
So like you put like some saran wrap on them, basically.
Yeah, something to identify. So they visually could tell they were different.
Wow. That actually sounds like fun. Like I feel like I would like to do that. Like I guess I'm a very competitive dude.
I'm glad you said you want to do that because that's what we're going to do.
Nice.
We're going to do things. And it doesn't have to be that specifically. That's just what I happen to do today. There's tons and tons of ways to train impulse control. But the big thing is get them moving and thinking simultaneously. That's a really important part of brain recovery and concussion recovery. And then find a task that you can start to build automation and then find ways to alter that task for whatever the specific trigger is that you want. So for this instance that we explained, it would be impulse control, making a go, no go response very quickly.
Gotcha. And like we had mentioned, having a baseline of that would be great to have, so that you can see just how much this concussion caused your brain to malfunction or be disinhibited. So you could, you run a baseline test with this.
Exactly.
With this iSync, and then say something happens, and then you can run it again, and you can say, okay, well, this is what was damaged. Like, so I know that in my in my field of work, we do all kinds of preliminary testing, specifically on us, say our ears, because we're in a loud environments. And we mentioned this in the last podcast, the video. So having this as a baseline, I think would be great. Like as a matter of fact, a friend of mine, his son just went through MEPS. And if there's anybody in the military listening, they know what MEPS is. It's kind of like the initial checkout of all of your symptoms. Hey, and they ask you a bunch of questions. And a lot of times, people, you want to do good. You want to get a good placement. And when the person, the doctor asks you, hey, how's your, have you ever had asthma? Have you ever had trouble breathing? They're like, nah, man, I'm all good. Nope, I'm all good. Never, nope, fine. I'm good. I'm good. Like to institute this testing in that would give a baseline, 12 minutes, 12-minute test across, and then have a baseline visual vestibular system. So you could have a vestibular baseline. How am I trying to say this here? I'll have to cut this out. So you could have like a vestibular baseline.
So you could have an ocular motor and some vestibular component baseline, but the important part about eye movement is it doesn't just tell you how well someone can coordinate their eyes to look between different points, it tells you what's going on in the brain. So eye movement is the one physical modality that captures every functional component of the brain that we would want to know about. So you're exactly right to say that having that baseline information is so important, so that way if there were a concussion, you can go back and see if there was any effect that needs to be addressed.
Yeah.
And the example of the athlete that had 100% on her antipsychotics, you need to know what someone's best performance is on that, so that way you're treating things that need to be treated. So if their baseline was 60% on antipsychotics and they, after a concussion, they score 40, your goal is going to be to return them to 60, not to return them to 100.
Right, because trying to return them to something that they weren't before, you're
not using your time wisely. And then also, some people have a strabismus where one eye kind of can people might think of it more as like a lazy eye. And like they might just have baseline differences since birth. It's not worth trying to fix something that likely had always been there.
Yeah.
And like that part, up until using this computerized assessment, I would have to rely on parents, friends, or family, or even just pictures that they had beforehand. Because if I don't know how their eyes cooperated beforehand, like if they did have one eyelid that drooped, or if they always tilted their head, that's important for me to know, because otherwise I think that there's some sort of lesion that's affecting the ability of your eyes to intort or extort. So sometimes the compensation for that is to tilt the head. So it's hard to know what's symptomatic versus what's their baseline.
I gotcha.
And like you can waste an awful lot of time trying to fix something that was there initially without having that good baseline information.
Yeah.
Now you mentioned MEPS. And if there's anybody on the healthcare provider side that's listening to this, they had a very visceral reaction because they thought you said MIPS.
MIPS.
So MIPS on the healthcare side is like merit-based incentive program that the government released for Medicare payers, and then all other payers started adopting it, where we have to provide this extra information every time we see a patient. So just to calm the listeners out there that might be on the healthcare side, that MIPS and MEPS are two totally different things. That on his side of things, MIPS is not something that has a strong adverse reaction.
MEPS is Military Entrance Processing Station.
Right. So they're looking at their physical health, their cognition, all that kind of stuff.
Right. Yeah. And everybody that goes into the military goes through it.
Yeah.
And I know that they keep a lot of information about, there's a lot of medical studies done because they keep such good records of people who are in the military. So there's a lot of stuff, a lot of cool studies that
and they're very thorough.
Very thorough.
In the MEP side of things, like they get everything from cardiac function, GI, everything. So you're right. Like having that data is so important for people that are going to be in situations where they might be more likely to sustain a situation like that. So somebody who maybe drives for a living, somebody who's an athlete, somebody who's in the military, any other scenario where whiplash or head impacts might be something you encounter on a more regular basis.
Wow. Yeah. Somebody that drives for a living, even like somebody who drives maybe like a CDL truck driver, it would be, maybe pretty smart to have a baseline study. I can see this like really being very important, more important than people give it credit for. I mean, like I said, hearing tests are kind of baseline for a lot of places. And then you can tell if your hearing gets worse over time. So with this, I mean, and I don't know everything about it. I'm not trying to
you're not selling these devices.
I'm not selling these things. Like I don't have any investment or anything in this,
but yeah, you're right. Like this, it's completely changed how much information we can have and how well we use our time on the clinic side. But another big misconception is that, for athletic trainers and sports PTs, they're used to eye movement screening. So it's called BOMS, vestibular ocular motor screening, to be purely symptom based. So if an athlete has a suspected concussion, they're doing the same thing I did with you, but with their finger or a pen, having them perform smooth pursuits, having them perform saccades, having them do a VOR. But they're relying on a positive test to be whether the athlete reports that makes them dizzy, nauseous, or have a headache, not the quality of the eye movement. Whereas on the clinical side, so sometimes when we bring up, ocular motor screening, their impression is just what they have had to learn for their side of things, which is just see if it makes the person symptomatic. Versus on our side, we're looking at the quality of movement. So before I had a device like this, we would have to wait for a patient to be able to get into a place that did this computerized testing, which was very hard to do because there's only one in our area that does it. It could take a while to get in to get that test done. And then we have to wait for the results. We have to wait for the doctor to review them and then pass them along if the doctor's kind enough to do so. Versus now I can get that information instantaneously. So now that changes the patient experience because we're dealing with real information that I can show them and reproduce. We're dealing with something that now we can show if there's progress or not. Are we affecting what we think we are? And I can even take that data and show their athletic trainer or show their doctor, this is what I'm seeing. This is the area I want to fix before they're back to 100% in sports. But the hard part about that is beforehand, for years, I was doing that all manually. So we would always analyze eye movement. And you would, follow whatever target I had. And I'd assess if you were undershooting or overshooting. And the tough part is, how do I make that make sense to a parent or another doctor if I can't reproduce that without the patient in front of me? So it just changed quite a bit in terms of how people understand eye movements to be able to analyze concussions.
Gotcha.
So another thing that you brought up that we were going to discuss on here is partway through the week, you had said that you're interested in becoming an EMT.
Yeah. So, let's talk about I think that stuff we delved super into the technicality. Let's get a little less technical for a second. Yeah. So, I think I think being an EMT would be cool. So I love medical stuff, obviously. I've taken a few rides in ambulances. I think 3 or 4.
As a patient?
As a patient.
It's a little different experience as the EMT, probably.
Yeah. So I feel like I maybe kind of want to give back.
Okay.
They've helped me.
Okay.
And I'm a pretty calm type dude. I don't get too panicky in crazy dramatic situations. I have the tendency to be able to keep a cool head. And I'm pretty good at talking to people when they're panicky and maybe being able to set their mind, talk in a way that kind of keeps them calm. Plus I like to, I want to help people.
So what would your expectations be if you were all the way through your training, you're going to start being an EMT tomorrow, you're going to go out on your first shift. What do you expect would be your day?
I mean, what do I expect? I expect that I would go to the firehouse, be putting on my EMT gear, and somebody would call. I would get a call, and there would the station would get a call, and they would dispatch me out, and I would go and basically rescue some people. Maybe there would be somebody that broke their leg, or maybe there'd be somebody smoke inhalation or car accident, maybe a car accident in this area, probably some maybe an overdose. I imagine that there would be quite a few of those. In my luck, it would probably the first one that I went on would probably be something drastic, like a bus crash, and there's 30 people that are legs are broken and
things
bloody.
You can't unsee.
Yeah, things I can't unsee. Kids, and I'm sure it would be very, very difficult thing. Yeah.
Yeah. So that's one thing that came to my mind is that the situations you can encounter likely are going to be really graphic.
Yeah.
If you're the first one there. And what would it do for you if you were called to the scene of somebody who had a motorcycle accident?
Oh, man, that's a good question. I never thought about that. I feel like that I could separate myself and kind of do what I needed to do to help the person. And
let's say they're unconscious.
Okay, they're unconscious. I'm being tested already.
Well, no, I'm just saying, no, not like, what's your clinical procedure? No, like more along the lines of like, what do you think that would do to you in terms of like, would you expect that to be a haunting experience? If someone who's in the exact same position that you were, do you feel like that would be something where you feel like you're in that role of giving back? Or is that going to be something that's going to bring up some tough memories or realizations for what it was like for everyone else on the other side?
Sheesh, Ab, I don't know. I never thought about it that hard. I'm a very, what would you say? Inquisitive dude. Like, I don't know how I would feel.
Yeah.
But I would like to find out, like, how I would feel.
So that was my first worry for you, is that do you really need PTSD on top of everything else that you're working through? But you didn't feel like that would be something that would be too haunting for you, like seeing some really tough things if you're the first one there. At least if you're like on the hospital side, they've already taken care of the majority of the unbearable side of it and kind of just packaged up this patient and brought them to you, and you know what to expect. You know, you get a call saying, burn victim or something where an appendage gets cut off or something graphic. You have a little bit of an expectation, but if you're the first one there, all you have is the details that were given over the phone. And it might just say bad car accident, or it might just say person fell, or something else just relatively broad. And then you're the first one there. And then you find out what that consequence could have been from what was explained over the phone.
Yeah, good question, Ab. I don't know. I do think that I could handle it, though. I think that, I don't know. I don't think you really know how you'll react to anything until you're actually in that situation. Mm-hmm. Like, you'd like to think, oh, yeah, I'll be cool, calm, collected, no problem. But then you get there and you're just like, what do I do? Mm-hmm. So I remember that, like, the first time I dive underwater, like, I thought I was going to be this, like, awesome cave diver, and it was, like, so easy. And in the pool, in the swimming pool, it was. And then the first time I actually was underwater, like real water in a quarry, and it was all dark, it was a completely different experience. I was like,
yeah,
screw caves. No way am I going in a freaking cave. No way. Like, instantaneously, it was like, no way. But before, I was all about it. I was like, yeah, that'd be so cool, man. I'll be like taking I'll take my gear off and shove it through this hole, and then I'll climb through the hole in the cave underwater. And then I get underwater and I'm like, no, that's never happening. Never, ever going in a cave, ever. So yeah, the expectation versus reality were certainly different. So I don't know. We'll have to see.
Yeah. And the other reality is that you're going to be an EMT in this area.
Yes.
And expecting that you're going to be able to show up and people are wanting your help and receiving of your help might not be the circumstances every time.
Right.
So sometimes being called to a situation where, like you mentioned, maybe an overdose or a friend or a family member is concerned about somebody who's in an unsafe situation, they might not always want your help. So that's important to gauge your expectations as well, is that the times when people need help and are appreciative of your help might not be all the time.
Yeah, for sure. So this guy at work, Mike, we'll call him a friend. He's a little strange, but he used to be a cop, and he told me the other day, he's like, yeah, man, I've seen so many EMTs get punched by people who they Narcaned because they were mad that they took away their high. I mean, but I'm not like a little puny guy, I can take a punch, or I can dodge a punch, or I would say that I'm not.
So you're not in that category of somebody who's had a concussion and is now hyper aware of other things that could create other concussions. If you're feeling willing to take a punch,
I guess not.
I guess that's not in your realm of concern. Well, I mean, it's important to have healthy expectations with that, but maybe at one point, a good friend of mine's an EMT. Maybe he'd be willing to come on here and explain his experience in that role, the kind of calls that they take. A lot of them are for things that might not feel as the best use of resources, and then other times where it's just super high intensity and you've got a lot to manage in a little bit of time. But I'd also be curious about what his approach is with known head injuries when he shows up on a scene.
Yeah.
Because a lot of people will say if they're conscious that they're fine.
Oh yeah. I said I was fine.
See? Great example.
Yeah.
Once you became conscious, you had no interest in going to the hospital.
None whatsoever. Like they said, I was even like combative at the scene. Like I was like, no, not
Which
going.
is another sign of a head injury. Yeah. So I'd be curious to see if he has any stories that would relate to that in terms of his experience as an EMT and what he has been able to learn from his experience with car accidents, major falls, other things that could lead to head impacts. Even after like fights or domestic violence, there's head impacts that come with that.
Oh yeah, for sure. Yeah, that could be dangerous.
Oh, for sure.
Yeah, and a friend of mine, I have a friend, he's a firefighter / EMT. I guess he does both. And he said that what you just said exactly. He said that, one time you'll get a call, and he gave me an example of a guy. He would call and find out what what the hospital was having for dinner. And if it was something that he liked, he would call and say, hey, I'm not feeling good. Like I'm having heart palpitations. I can't, I'm having an asthma attack, diabetes. And ambulance would drive out and get him, take him to the hospital. He would get dinner, and that was that. And then they would take him back home. And he said this guy did this so much. He was on an ambulance more than most ambulance, oh, come here, Bren.
Most EMT drivers.
Yeah, most EMTs.
Wow, he's fine. There's somewhere some poor clinician has to do a MIPS outcome survey based on that guy who utilizes ambulance-based services to be able to go have the hospital-based dinner.
Yeah, and he said that, like, they actually gave him some, like, EMT award or something because everybody knew this guy so much. Then he said one time
like most miles.
Yeah, most miles. He said one time that he hadn't called in like a week, so they got worried.
They called him.
Yeah, they went to him. They were like, let's go check on him to make sure he's okay.
We're gonna reverse 911 this one. We're gonna show up to him.
Yeah,
offer aid and see what happens.
He says so. You'll get people like that, and then you'll get a car accident where you see a kid that's in a windshield.
Yeah,
he's like it is that drastic difference.
Yeah. Oh yeah.
So yeah, I've certainly been asking people and trying to get the full gamut, and I'll talk to, I'm sure I'll do like an interview and everything at the firehouse and
lots of training, I'm sure. Yeah. And then when are you going to fit that in?
Yeah, that's a good question.
Because I think it's a big time commitment.
Yeah, so it's like 200 hours, I think, of like training. Mm-hmm. I don't think that's all in a classroom. I think some of that's online, maybe.
And then once you do the training, I think you have to do a certain amount of hours at a firehouse.
Yes.
So you're going to do that on the weekends?
Probably on the weekends. We are going to have to hire an editor.
Right.
Yeah. So
to be able to get these things out while Travis is out EMTing.
Yeah. Well, I'm not sure how much I'll be actually EMTing. So they said like maybe for the first year probably, because it's like so much training, you know. It's like they said maybe like one Saturday for classroom and then like maybe one night, like one evening. So I don't know. I still really don't know much about it.
Yeah. Well, it'll be good to investigate and see what the options are and see how you can fit it in.
Yeah.
If it's something you want to do.
Yeah.
But that's neat. All right. Well, we'll wrap up for tonight.
Yeah.
And once that YouTube video is posted with the iSync findings, it'll be neat to see where we're starting and then what we're going to do with Travis to be able to address all those findings and see if we can improve some of the factors that we saw that we could improve.
Yeah. Oh, I'm excited to get down to that.
Yeah.
Like I've been thinking about it. Like I said, I was like, oh, yeah, I was going to text you. I was like, oh, I got to text Ab and ask her, you know, what are we going to do? Like, because I've been curious, you know, and then you say dropping the things and that's just one thing. So.
Yeah. Yeah. But there's all sorts of things. And like the cool part about the iSync is I can try something, retest it, see if we influence what we thought we were. And if not, back to the drawing board, figure out something else.
Nice.
Yeah. So it's a kind of a neat trial and error process, but with real data.
That'll be awesome.
Yeah. All right. Well, we'll look forward to speaking with you all next week.
Yeah. All right. Thanks, everybody. See ya. Thanks again for tuning in to Concussion. If you found this episode helpful, be sure to follow us and share it with someone you may think will find it useful. You can catch us on Spotify, YouTube, or wherever you get your podcasts. For updates and behind-the-scenes content, check out our TikTok, Instagram, and X. Or join our growing community on Discord, where we dive deeper into concussion recovery and support each other along the way. All links are in the description, so see you there. And until next time, keep your head in the game and keep it protected.